Good evening. I am Dr. Fatma Akyüz Karacan. I am a psychiatric specialist in Bezmi Alem University. We'll be speaking about depression. He's now with us, but he couldn't be here because of his health problems. He sent his salutes to everyone.
Kanser ve depresyonu anlatacağım. Yemek öncesi biraz sıkıntılı bir konu. Başlayalım bir yandan. Kanser bildiğiniz gibi hastaların ve yakınlarının hayatını etkileyen uzun süreli hastalıklarından birisidir. Özellikle gelişmiş ülkelerdeki ölümlerin %25'ini oluşturmakta, ölüm sebeplerinde kalp hastalıklarından sonra ikinci sırada yer almakta. Son zamanlarda tüm insanlığın en önemli ve en trajik sonlarından olan kanser, insanlarda genel olarak ölüm korkusu, umutsuzluk, çaresizlik, yalnız kalma, kaygı, tepki ve düşüncelerini oluşturmakta. Yıllar içerisinde kanser tedavisinde yaşanan tüm gelişmelere rağmen kanser tanısı alan kişilerde anksiyete ve depresif duygular uyandıran, zaman içerisinde belirsizlikler içeren, ağrı ve ölümü düşündüren bir hastalık. Kanser hastalığını ilk defa duyduğumuzda ilk aklımıza gelen şey bizler için de hastalarımız için de ölüm kaygısı ve çaresizlik artı belki kanserin ruhsal belirtilerinin bu kadar olmasının nedenlerinden bir tanesi de belirsizlik. Beklenen uzun bir tedavi süreci var çünkü. Kanser için uygulanan kemoterapi, radyoterapi gibi tıbbi tedaviler her ne kadar yaşam süresini uzatsa da fiziksel ve psikososyal sorunlara neden olmakta. En sık görülen psikiyatrik sorunlar, uyum bozukluğu ve ağır düzeyde depresif semptomlar. Bildiğiniz üzere kanser hastalarında radyoterapi, kemoterapi gibi tedavilerle yaşam süresi uzatıldı ama burada da psikiyatrik belirtilerde artış, ilaçların yan etkileri artık tedavinin ve tedavi sürecinin verdiği duygusal tepkilerden ötürü de en sık görülen psikiyatrik bozukluklar, uyum bozukluğu ve depresif bozukluk. Majör depresyon tanısı kanser hastalığında incelikle incelenmesi gereken çok önemli psikiyatrik bozukluklardan olup hastanın yaşama olan bağlılığını, öz bakımını, kontrolleri olan uyumunu ve zamanla kanserin tedavisinde yanıtını etkilemekte. Aslında bu tek depresyon için geçerli. Bu arada çok özür diliyorum. Bir sesimde çiftleşme var ama çok boğazımda bir sıkıntı var. Aslında kanser hastalığına eşlik eden psikiyatrik belirtilerde hem yaşam kalitesinin etkilendiği hem de tedavi uyumunun etkilendiği gösterilmiş. Tabii ki bu depresyonda daha belirgin olarak ortaya çıkmış. Tedavi edilmeyen psikiyatrik semptomlar yaşam kalitesini ve yaşam süresinin azalmasına neden oluyor. Çünkü neden? Tedavi uyumu azalıyor. Tedavi uyumu azaldığı için de yaşam süresi azalıyor. Kanserle ilk kez karşılaştığında kişi kanser tanısı sonrası gelişen yas reaksiyonlarında aşama ilkinde şok ve kabullenmeme. Bu daha kısa süreli olabiliyor saatler ve günler içerisinde ve burada şundan bahsediliyor. Hekimlerin hastaya hastalığı söylerken biraz hazırlayıp daha sonrasında söylenmesinden bahsediliyor literatürde. Ama biz biliyoruz ki onkolog arkadaşlarımız bunları daha hızlı bir şekilde söylenmekte. Ama önerilerde kişilerin bunlara hazırlanıp tanının ondan sonra söylenilmesi. İkinci dönem öfke, daha sonra pazarlık, depresyon ve kabullenme aşamaları var. Ve kişi kabullenmeyi yani kanser hastalığını kabullendiği zaman tedavi uyumu artmakta, tedaviye verdiği cevap.
When an individual accepts cancer, the treatments is more accepted even more. There are many diagnoses and treatment modalities with this regard. Chemotherapy, radiotherapy, surgical methods and other methods are being implemented on the patient, and patient feels an anxiety. First phasing is being done, a treatment protocol is being created. Until that treatment is created, there is an uncertainty. And surgically speaking, when the mass is being taken, the patient has a dependency feeling, and this eliminates the freedom, and the patient also has a mourning for the lost organ, especially for the breast loss. There are some studies. Sometimes patients are losing their functionalities, which causes depression after operation. And there is an uncertainty because of The patients have the anxiety of dependency, and this uncertainty increases anxiety and causes a depressive mood. While the chemotherapy side effects come to fore, there is an anxiety time. The nausea, loss of hair, adverse effects, infection risk, and all other risks are affecting negatively the psychiatric situation of the individual. The study is implemented for this reason. For example, hair loss is shown to have affected people, and it's causing anxiety and other depressive results. Strong chemotherapeutic drugs are being given. Nausea, diarrhea, and other clinic symptoms have an effect on mood. Also, after treatment, there is a repetition, a fear of repetition or the recurrence, and there are also compliance problems after treatment. Cancer is not something like this. You are cured, go home. You are having 3 monthly or 6 monthly controls. We see that there are high level of anxieties in individuals when necessary intervention is being made. They have a better compliance and controls. So once chemotherapy and radiotherapy is over, the recurrence, the anxiety of recurrence is affecting the individuals, and we are recommended to interfere with this. Speaking about depression, especially cancer patients are showing major depression, compliance problems, and adjustment disorders. In 10 to 25% of the patients, we can see major depression and similar clinically significant symptoms are being seen. When all these are taken into account, it's shown that cancer patients have 2 or 3 times more depression compared to the other general population, and it's a wide range beginning from the depressive symptoms to major depression. I will be speaking about this soon. There is a depression aptitude here or tendency, but from depressive moods, they might go to a point where the range is fitting in the major depression symptoms. After there is a 40% of high depression level once the cancer is diagnosed, and 20% are displaying severe depressive disorder, and the other half is a mild depressive disorder. If we don't see the major depressive disorder, the risks will increase, life quality will go down, treatment compliance will go down, and even suicide can follow, and there is a lot of emphasis on this. There are research related to the various therapies. It's shown that anxiety and depression is treatable in cancer patients, and this treatment is contributing positively to patients in terms of coping with disease. Depression should be absolutely treated in cancer patients. Otherwise, the cancer treatments adjustment is going down, and there are also more pain, fast progress in cancer symptoms, morbidity increase, and a certain level of increase in mortality. I will be discussing it soon. For example, one is being diagnosed cancer. We don't need to necessarily see a kind of grief. If you see a depressive situation, you should treat at all costs because it has an effect on compliance to treatments, adherence to treatment, and life quality. Depressive cancer patients are asking for more euthanasia and medical aided suicide. When we don't treat depression, euthanasia and doctor mediated suicide is coming to fore. We don't have it in our laws, but some countries have it. When depression is not being treated, these options are increasing. Most important of all, if we don't see this depression in our clinic practice, there might be an increased rate of suicides. Major depression and cancer, when they are coming together, increases the risk of mortality. How depression is diagnosed in cancer patients. There are studies about this. If there's a clinic situation, if it's more than sadness or grief, if it's a loss of energy, loss of sleep, all these have an effect on cancer patients, and it's also frequently seen in other medical diseases. There's an emphasis in literature on this. When someone is diagnosed with cancer, people can show grief, sadness, sorrow. These are based on the diagnosis of the disease, and these are not seen as comorbidities. There is a concern about this. But if the criteria are fitting in major depression criteria, we should look at them and we should treat them. Sometimes this can come to fore as an adverse effect of the treatment administered. Many medical conditions contribute to the depressive situation. These are uncontrolled disease, hypercalcemia, anemia, glucocorticoid, interferon. Some chemotherapeutic agents might have side effects of depression, and we should take them into account too. In cancer patients, while diagnosing cancer patients with depression, we are using normal major depressive diagnosis criteria. When we don't see as an unhappiness or sorrow or sadness depending on the disease, we have to look at the criteria and to diagnose accordingly. Oncologists and oncology nurses are very important in this regard in order not to ignore these symptoms. Depressive mood, loss of interest is 91, sensitivity is 95%, negative prediction is 18%. She is reading the figures on the slide very fastly. If there is additional disease, there might be some additional loss of faculty. Feeling valueless or worthless is another important marker for this. The cancer patients will protect self-respect, while the depressive patients does not protect this. The suicidal thoughts are widespread in cancer, but it's not as widespread as depression. Looking at the major depression findings, if we shouldn't accept that a cancer patient normally have these findings, but sometimes the other physicians are associating these findings with the nature of the disease, and the psychiatric support is either late or inexistent for the patients. This is not only emphasized in our country, but in all the world, this is being emphasized. And what can be done for early diagnosis? And we are told that depression scales can be used for oncological patients. It's important to train oncologic nurses. This is also emphasized by literature. And also, as I will be speaking in the upcoming slides, we need a psychologist or psychiatrist in the team, because our biggest problem is that these are overlooked. These are not seen. Quality of life and adherence to therapy has a bearing on life term. When we look at the risk factors, genetic, gender, psychosocial factors, trauma, coping strategies, family, relatives, psychosocial communication, deaths, neurobiological changes, neurotransmitter changes, stress hormone, immunological changes, change in functionality and brain structure, as well as hypothyroidism. The factors stemming from care and treatment, which are cancer-dependent, prognosis and the phasing of the patients, are effective on this. It is shown that advanced, progressed cancer patients have more depression. Also, limitations in functionality. If someone is dependent on another individual and cannot carry out his or her own care, this can increase depression. The damaged bodily image, especially in young patients when an organ is being lost, this is also effective. Chronic pain increases depression. Adverse effects coming from treatments and care, metastasis, and paraneoplastic syndromes can accelerate depression.
So if there's a previous psychiatric disorder, I will actually emphasize later that cancer patients, as you know, are not only individual, it is a family disease. So it has an impact on the relatives, close ones of the patient as well. So in the therapy of an individual, the social support is underlined for amelioration. And when there is lack of social support, then psychiatric diseases are seen to be more frequent. Lack of self-confidence, self-respect, substance abuse, alcohol abuse, lack of pain control, psychosocial interventions, psychosocial support groups are all of the factors that I will refer to. I also want to refer to relapse. When there is a repetition in the patient, when she is first diagnosed as cancer patient, there is also denial, also lack of sleep, lack of appetite, lack of hope, and severe depression might be formed. And in the advanced stages, the patients look for alternative therapies. For instance, in oncology patients, what happens is there is the phase 4 advanced level. So they are looking for remedies, and there's this uncertain therapies. You must be hearing them, and there are really high amounts of money where these therapies are being sold. And the patient starts to fear dying lonely, and also there is a severe lack of hope. And in the relapse period, the clinical applications might be more frequent and the symptoms might show themselves more frequently. I also put suicide here. İntihar means suicide in Turkish. When an individual deliberately loses one's own life, takes one's own life. So it might be only on a level of thought, or it might also be completed. As you know, the suicide risk is male gender, being alone, not married, chronic diseases like cancer. These all are some of the factors that are underlined in the recent literature, especially. So attempted and completed suicide cases mostly have one chronic disease accompanying, and the risk of suicide in cancer patients with accompanying disease is higher, and the suicide risk of cancer patients when compared with non-cancer persons are higher, and there are also additional risk factors in cancer patients. So some of the risk factors are physical lack of strength, cancer disease duration, 1 year and more, especially if the duration is longer than 1 year. Phase of the cancer, advanced phase, and inoperable cancer, type of cancer, depending on the limbs and organs, especially with more pain, physical mobility loss, meaning honor and status loss. And actually these are risk factors for euthanasia. Together with the illness, the patient loses one's status, strength. So they also say that they can pick euthanasia or suicide. So there's this understanding in the whole history, and the load of symptoms. So actually, there is a higher risk of suicide, especially in those patients. If they have a story of cancer in their childhood or adolescence, then there is a higher risk of suicide in the adult years. So when we look at protective factors, so concerning substance abuse, there needs to be an effective clinical care, easy access, family and society support, continuing health services, conflict resolution services, non-violent ways, and cultural and religious remedies that help with one's own self-protection are among the protective or preventive factors. When we come to treatment, the cancer patient, cancer illness leads to many problems, physical, psychosocial, and economic, but a good social support is good for coping as well as the treatment and the increase of the quality of life, which means that if there's a good social support once becomes a cancer patient. So it is a protective factor against suicide and euthanasia. So the treatment is done by oncologist, nurse, psychiatrist, and healthcare professionals. And these persons need to manage the whole process. And in the literature, it says that with persons without family support, the palliative support units, care units, social service experts are of utmost importance. That the psychiatry and oncology nurses need to be trained, and in this sense, they can help with protective approaches for the cancer patient. As you know, there are many psychotherapy treatments applied to many individuals as well as cancer patients, and they have been helpful. When you look at psychotherapy treatments, there is call line as well as interview. So there's a whole range of support mechanisms. The literature says first you need to train your team and give psychoeducation to your team concerning the duration of the illness, treatment, adverse effects, and all the things that you might encounter. When a patient hears about these from the team, then their quality of life increases and the compliance with the therapy increases. And the literature also says that oncologists are not really good at it. Psychoeducation is something that is limited for the oncologist in terms of ability and duration, not only in Turkey, but the whole world. It's mostly the oncology nurses as well as social service experts that need to be trained and that need to be involved once a patient starts with a treatment. When there is a good psychotherapy, actually there are many types of therapy, like individual and group therapies. All these means are being used and they are found to be beneficial. But the easiest to do is to attain a psychoeducation. And the easiest person to train is either a nurse or a social service caregiver. And also calling by phone by the team, controlling the treatments, helping the patient to come to control sessions are all factors that increase the compliance with the treatment. So the psychotherapy here is distinct in the sense that it is specially tailored for the stages, symptoms, abilities, and inabilities of a cancer patient, tailor-made for a cancer patient, for the amelioration of symptoms, compliance with the treatment, increasing quality of life. So while the treatment program is being configured, the therapists need to be involved in the whole teamwork, which is emphasized. And now in Turkey, we are using these methods. And we are working with oncologists more and more in comparison with previous times. So there are various psychotherapy treatments, and it depends also on the stages of the cancer patient herself. So when you come to pharmacological treatment, it is an important part of depression therapy. So it needs to be known by the whole therapy team. So when the patient comes to you, she's not using only one drug. There are oncology drugs as well as additional illnesses. So when we start with a drug, so the oncologist needs to know about these as well as the rest of the team. And there are some neurobiological changes that need to be distinguished, and the suitable antidepressants need to be selected for the patients. So there are antidepressants, SSRIs and SNRIs as especially recommended first. I think it leads to destruction in the liver, SSRIs. Therefore, SNRIs are opted. So when we start with the antidepressants, we need time for it to have an effect. And the patients are in such a situation that when we go to consultation, they have severe anxiety and problems. So we have anxiolytics that we administer sometimes depending on the patients. And benzodiazepines, if it's a psychotic depression at stake, then antipsychotics are recommended. Risperidone and onazepam were also recommended in low doses. When I go to consultation, I use hariperidol, and among SSRI and SNRI, valproxen is especially recommended. Valdafaxin leads to destruction of tamoxifen. Therefore, be careful about the interaction of drugs. It might lead to the destruction of the chemotherapeutic agent. So the oncologist has to know about the drug that we administer as psychiatrists. And we have to be in touch with one another among psychiatrists and oncologists. So, conclusion. Cancer means psychosocial problems as well as lack of job, employment. Therefore, it has adverse impact on the quality of life on the patient. But then there's a lack of emphasis on the psychiatric side of it. We have to be careful. We have to evaluate psychiatric symptoms very carefully, refer to treatments, and there needs to be a team managing the whole process, and there has to be a psychologist or a psychiatrist in the team. Thank you very much.